Good afternoon, everyone. Thank you for joining me today. My name is Suhaas Muralidharan, and I'm a second-year PhD student in clinical pharmaceutical sciences at Purdue University. I'm working with Dr. Sarah Queenie on studying labetalol pharmacokinetics in pregnancy, and that will be the focus of my presentation today. So to begin, I'd like to give you a bit of background on hypertensive disorders of pregnancy, um, also known as HTPs. The HTPs affect about 18 million pregnancies annually and increase the risk of adverse maternal and neonatal outcomes. And if we look at the classification of HTPs, it's really based on the timing of onset during the gestational age of onset, and the severity of the hypertension and whether it leads to end organ dysfunction and proteinuria. So you can see chronic hypertension is when it's diagnosed before 20 weeks, and post 20 weeks, it's classified as gestational hypertension, and the presence of proteinuria determines whether it's preeclampsia or not. And so to clinically manage these hypertensive disorders of pregnancy, labetalol is the chosen first-line agent. And if we look at labetalol, there's a limited guidance over its optimal dosing in pregnancy, which in turn leads to a large variability in clinical response to labetalol. We also know that a number of physiological changes occur during pregnancy, which include the increase in cardiac output and plasma volume, which could affect plasma concentrations of a drug. There's an induction and inhibition of certain enzymes during pregnancy, which can alter pharmacokinetics. Um, we also have delayed absorption and a potential for increased excretion in pregnancy, which can further affect the pharmacokinetics of drugs. So we know these physiological changes in pregnancy can alter the pharmacokinetics of drugs, but we do not fully understand how these affect labetalol metabolism. And so let's talk a little bit more about labetalol. So labetalol is a chiral molecule and it has two chiral carbon centers, which basically means that it has a carbon atom that's bonded to four different substituent groups. And this allows it to exist as a mixture of two diastereomer pairs or four stereoisomers, out of which only two are pharmacologically active. So as you can see here, the two pharmacologically active stereoisomers are SR-labetalol, which is known for its alpha-1 antagonistic activity, and the more predominant activity is caused by this RR-labetalol, which is a non-selective beta antagonist, also with some alpha-1 antagonistic activity. So these stereoisomers differ in their spatial arrangement and can have different physicochemical properties, which in turn leads to differential pharmacokinetics and differences in the way they interact with the receptors, which can in turn lead to differential pharmacodynamics or response. So the hypothesis of our study is that these differences in the pharmacokinetics and labetalol of labetalol stereoisomers can cause the variability in drug exposure and response during pregnancy. And so with that, the objective of the study is to characterize the pharmacokinetics of labetalol stereoisomers during pregnancy and postpartum. So to study this, we're conducting an observational pharmacokinetic study where we're recruiting pregnant women who are taking labetalol as per standard of care. We exclude any patients who have diseases that are known to alter labetalol pharmacokinetics. And our study visits include three different types. So we have the pregnancy study visits where we have the patient come in during their morning or during the time of their morning labetalol dose. We have them do their vitals, and then we start collecting blood draws. So we do a blood draw before they take their dose, and following their dose, we continue taking blood draws at specific time points. And we also collect urine throughout the study visit. We also look at pharmacodynamic measures of response, like the blood pressure and heart rate. During the postpartum visits, the only added component is that we also look at breast milk if the patient is breastfeeding. And we also have delivery sample collection, which includes at the time they're admitted for delivery, we include collecting a maternal blood sample, a cord blood sample, and amniotic fluid. And this is mainly to assess the fetal exposure to labetalol during pregnancy. So the goal is to then quantify the amount of labetalol stereoisomers in these samples using a chiral LC-MS-MS assay, and then use population pharmacokinetics to study the effects of covariates like body weight, gestational age on labetalol dosing in pregnancy. So where we are right now is that we have assessed about 154 patients for eligibility, and out of them, 13 of them have been enrolled to the study. 6 of them had to be withdrawn, so we have 7 active patients, out of which 6 have completed at least one study visit. And we have collected 6 pregnancy samples among these patients, and out of them, 3 of them have completed 2 study visits during pregnancy. We also have 3 delivery samples, and 2 of them have come in for postpartum visits as well. So this is just to show you the demographics of the patients who have participated in our study. And just to keep in mind that the estimated gestational age is either at the first visit, which is for most of these patients, or at enrollment for that one patient who didn't complete a study visit yet. And so with that, the goal of the study is to ultimately understand the stereospecific PK-PD relationships, which may help predict and interpret patient variability and inform trimester-specific dosing strategies to optimize outcomes in hypertensive disorders of pregnancy. Finally, I'd like to acknowledge the members of the study team for their support with the study. Firstly, I'd like to thank Dr. Sarah Queenie, who's my PhD advisor, for giving me the opportunity to work on this study and also the resources as well. And I'd also like to thank Brittany and Shelley, who have helped a lot with the organizing the study visits and scheduling the patient recruitment visits as well. And of course, my fellow graduate students who have helped me with the study procedures. I'd also like to thank the physicians and nurses at Indiana University Hospital and Eskenazi Hospital for all their contribution in helping with the recruitment efforts. And of course, I'd like to acknowledge our funding sources as well. But with that, I'd like to thank you for your time and attention and open the floor to questions.